Today, a case of acute diarrhea. A case of 65-year-old man complaining about diarrhea. Introduction of case. A 65-year-old man goes to his general practitioner complaining of diarrhea. This had developed suddenly 2 days previously. Sign and symptoms. His motions are watery and foul smelling. There is no blood or mucus in stool. There is colicky abdomen pain not relieved by defecation. The man has a poor appetite and feels nauseated. He feels tired also. History of the patient. The man has recently retired and returned 2 weeks ago from a coast trip. No one else on the coach was ill during the holiday. No, he is otherwise well with no significant medical history. He smokes 10 cigarettes a day and drinks 2 pints of beer a day. Examination is unremarkable and the GP diagnosed traveler diarrhea and described loperamide. 2 weeks later, the patient returns. The diarrhea persisted and patient was lost 6 kg in weight. Loperamide drug indicated or contraindicated according to KD Tripathi book. Indicated the utility of antimotility drugs in diarrhea is limited to non-infective diarrhea. Mild traveler diarrhea. Diarrhea is exhausting or idiopathic diarrhea in AIDS patient. Low doses may be used for chronic diarrhea in IBS. Antimotility drug can be used to induce deliberate short-term constipation, example after anal surgery, and to reduce the volume, fluidity, and back cleaning frequency in ileus colonoscopy patients. Contraindication of loperamide in acute infective diarrhea because they delay clearance of pathogens from the intestine. If invasive organisms, Shigella, are present, antimotility drugs can be disastrous by increasing the risk of systemic invasion. Antimotility drugs are contraindicated in severe disease since they may raise intraluminal pressure. Examination of patients. On examination, the patient look well. His blood pressure is 158 diastolic and 88 systolic mmHg. Cardiovascular, respiratory, and abdomen examination are unremarkable or normal. Questions are: first question is, what is the likely diagnosis? Second, how would you further examine, investigate, and manage this patient? Question first, what is likely diagnosis? This patient has diarrhea and weight loss due to giardiasis. Giardiasis is a infection of upper small intestine caused by flagellate protozoan Giardia labelia. Diagnosis: infection is mainly asymptomatic. However, when symptoms occur, they include acute and chronic diarrhea without blood or pus. In few cases, malabsorption syndrome may occur. Extraintestinal manifestations are rare and include allergic manifestations such as urticaria, erythema, multiform bronchospasm, reactive arthritis, and biliary tract disease. Investigations are microscopic stool examination of Giardia intestinals, tropozoitis, or cysts of infected patient. Sensitivity increase on serial 3 samples examination. More specific tests include stool, antigen, ELISA, or duodenal biopsy. Question 2. How would you further examine? It is important to take a care history in patient with diarrhea. An acute infective diarrhea develops soon after ingestion of offending food. The commonest infective cause of infective gastroenteritis are viruses such as rotavirus or bacteria, Campylobacter jejuni or Salmonella enteroditis. Staphylococcal food poisoning occurs within a few hours and typically present abruptly and may be severe but short-lived. Campylobacter, Salmonella, Shigella cause more severe symptoms than viral gastroenteritis. The incubation period of gardasis is typically about 2 weeks but varies from 3 days to 6 weeks. Garida lambelia infects the small intestine and cause a watery yellow, full-smelling diarrhea. Loss of appetite, nausea, and weight loss are common. Symptoms usually improve after 2 to 3 weeks but can persist in some cases causing lactose intolerance. Difference between the small and large bowel origin of the diarrhea, which help you in diagnose. Large bowel diarrhea maximal in the morning, pain in relieved by defecation, blood and mucus may be present. Small bowel origin diarrhea does not occur at any particular time. Pain is not helped by defecation. Typically, a pale fatty stool without blood or mucus occur in small bowel disease. If small bowel type diarrhea persists, other non-infective cause of malabsorption should be considered such as tropical sprue, colic disease and chronic pancreatitis. How would you further investigate? Diagnosis is made by finding cyst of parasite in stool sample. If stool samples are negative, cyst can be found on jejunal biopsy or by sampling duodenal fluid by asking the patient to swallow enterotest capsule. If no infective cause had been found for the man, diarrhea and weight loss, further investigate would have been necessary to exclude cause such as malignancy or thyrotoxicosis. How would you manage this patient? Treatment: drug of choice A. Metronidazole, adult and children over 10 years, 2 gram orally once daily for 3 days, or 400 mg 8 hourly for 5 days. Children below 10 years, 15 mg per kg per day in dividing doses for 5 to 7 days. Indicatively 1 to 3 years, 500 mg per day, 3 to 7 year, 600 to 800 mg per day, 7 to 10 years, 1 gram per day for 3 days. Second choice B. Tinidazole PO, adult, 2 gram orally as a single dose during or effect meal after meal. Children 50 to 75 kilogram body weight as a single dose, repeat once if necessary. Or C. C is secnidazole PO, adult, 2 gram as a single dose. Prevention of dehydration. Administration oral rehydration solution ORS according to WHO treatment plan A to prevent dehydration. Severe dehydration, use ringer lactate RL. Children under 5 years, 20 ml per kg of RL over 15 minutes to be repeated 2 times if necessary. Then 70 ml per kg of RL over 3 hours. Children 5 years and over and adults 30 ml per kg of RL over 30 minutes to be repeated once if necessary. Then 70 ml per kg of RL over 30 hours. Metronidazole, secnidazole, or tinidazole should be avoided the first trimester of pregnancy. Reduce dosing to 50% in significant liver disease. Key points are stool sample should be sent in patient returning from abroad with diarrhea. Always take an accurate history of recent foreign travel in patient with diarrhea. Attempt to distinguish clinically between small and large bowel origin of diarrhea. Gradasis is a common cause of traveler diarrhea. Like and subscribe for new cases. Thank you.